Good evening, everyone. Welcome and Happy New Year to everyone. And I hope your new year is off to a good start. I am Janet Jackson. I am the project director for the Minority Fellowship Program at the American Nurses Association. And the MFP team and I are excited that you've joined us to kick off our very first of 4 live mandatory educational offerings for fellows in our fiscal grant year 2023. And to help us do that, I'm happy to present to you Dr. Liz Stokes, who's the Director of Nursing Programs and Center for Ethics and Human Rights at the American Nurses Association, and Kara Curry, who's a Senior Policy and Ethics Advisor, also with the Center for Ethics and Human Rights. And since we've only have an hour together
one
tonight,
example, and
if we could mute our phones, that would be great. Thank you. Since we only have an hour together tonight, I'm not going to spend time reading Dr. Stokes and Kara's bios. You should have received an email today that included their full bios. And I also want to leave some time for them to share with you whatever they want to share with you about themselves. However, I will tell you that Dr. Stokes is a nurse, attorney, a bioethicist, and the MFP is now under Dr. Stokes and the nursing programs and Center for Ethics and Human Rights at ANA. And it's such a joy to work with Dr. Stokes. And she's doing an amazing job of bringing more visibility of the MFP within ANA and the broader nursing community. And Kara is also a bioethicist, and she has served as a pediatric clinical ethicist in the DC area. And so without further delay, I present to you Dr. Liz Stokes and Kara Curry.
Thank you so much, Janet, and thank you to the MFP team for hosting us. We're so happy to be here with you tonight. We're going to talk a little bit about the Code of Ethics and policy implications and how this applies to you. Now, this will be a very interactive discussion, so we need you tonight. So, be with us. We're going to send out some chat questions and some poll questions, and we're really going to have you tap into your brain, into your experiences, and share with all of us so we can learn together.
So, I'm happy to be here. Like it was said, my name is Kara Curry. I actually just started in the center just this past July, and my first introduction to ANA was actually at the MFP Summer Institute. So I've been here for about 6 months, and I'm excited to be back with you all tonight. But we'll just jump right into it since we do only have an hour this evening. But over the past several months, our Ethics Advisory Board has worked diligently to revamp the Center for Ethics and Human Rights vision and objectives. The previous objectives were established upon the center's conception back in 1990. So we are so proud and excited with what the EAB, the Ethics Advisory Board, has come up with for our new vision and objectives. And so we would like to share that with you. So the Center for Ethics and Human Rights advocates for and provides the vocabulary, framework, and a moral space to activate the code through ever-evolving circumstances. We enable and partner with nurses in all roles and settings so that they may act on the values of the profession to shift systemic challenges affecting the health and well-being of populations we serve, including individual nurses and the nursing profession. So some of our objectives are first that we want to advance practical strategies grounded in the ANA code to address ethical issues encountered in practice, education, public policy, and healthcare. We want to deliver timely analysis and guidance on ethics and human rights issues to advise, challenge, and advance the profession and fulfillment of its intrinsic relational commitments to patients, self, others, the profession, and society. And finally, we want to ensure integration of ethics and human rights concerns in all facets of the ANA enterprise. So it was very important that we were intentional about the application piece of the practical strategies related to the code, because the current state of our world, as you all know, introduces new and challenging circumstances that impact how we exist as nurses, how we practice as nurses, and participate as nurses within the healthcare system. And it's necessary that the vision and objectives are able to be translated to all of the ethical unknowns that await us in this decade and the next.
Thank you, Kara. And so as I look at our objectives, I'm really so glad we did this revisioning of our goal and our mission for the center. And that is one of the reasons we're here with you tonight. I look at the second bullet is to deliver timely analysis and guidance. And that's exactly what we plan to do, but also harping on some of your experiences as well. So we really just want to put the code into practice. So we have this document, it's the Code of Ethics. It's a long document, but it's a very meaningful document. So we pulled out some of the key pieces that apply to our discussion tonight and apply to you as nurse leaders and future nurse executives. So when we talk about advocacy, it's really clear, it's really good to understand that it's an ethical obligation. And so nurses are, of course, encouraged to do lifelong learning, which you are all doing right now, but also it's important to make sure that there's a wide range of social advocacy and civic activities. This continues throughout your profession, especially when you get to this level of professionalism in nursing. And then, of course, there's also pursuing leisure and recreational activities because we play hard, right? But we work hard as well. The other ethical obligation that's outlined in the code is making sure that nurses understand that they are responsible for ensuring that nurses, so the folks that are on your team, have access to an inclusion on organizational committees and decision-making processes. So you are now in these decision-making seats. So, you know, if you're not at the table, they always say pull up a chair, right? So we know sometimes in healthcare, nurses are not invited to the table. That's when we get our chair, we pull up to the table and we say, let's work, let's go. And so as nurse leaders, that's certainly the expectation and the ethical obligation from the code. And then lastly, our responsibilities, again, to ourselves, to our team, to our patients. And this is to make sure that people are treated fairly, justly. And this kind of speaks to the health disparities, which we're going to talk about in just a moment, but making sure, again, that nurses are in these decision-making seats and are making these decisions with inclusion in mind. So now we're going to talk a little bit about some of our position statements.
Thanks, Liz. So we want to just shift the discussion to the other work that we do in the Center for Ethics, and that is our work with the position statements. But first, we want to get your input, and you can put this in the chat, on what comes to mind when you even hear the term position statement. Anyone? You could put it in the chat. Core beliefs about subject matter. Thanks, Rashida. A stated position on a given issue, a stance, a viewpoint, values and missions, organizational goals, guiding principles. Thank you. Accountability. Great. So these are all great definitions of this term, this concept of a position statement. So ANA and our center develop positions that are relevant to nursing practice, to health policy and social concerns that are impacting the health of patients and families. And these position statements guide the profession. So someone used the term guiding principles. They amplify the views of nursing, and they also educate consumers and other decision makers. So we want to engage in discussion with you around several of the center's existing position statements. So we'll jump right into our first poll question.
So this is our first question. Have you ever cared for a pregnant patient who had substance use disorder and were unclear about the most appropriate ethical decision regarding their care? So again, have you ever cared for a pregnant patient with substance use disorder and were unclear about the most appropriate ethical decision regarding their care? The second piece is, let's assume that you did. Did you experience personal moral conflict when caring for this population? The numbers are coming in, they're coming in. Got maybe a couple more people need to answer, we're almost there. So again, have you cared for a pregnant patient with substance use disorder and unclear about the most appropriate ethical decision? And did you experience moral conflict when caring for this population? All right, I'm gonna end the poll here and share it with you. Thank you. This is great. This is why I love doing polls. So we've got about 50-50%. So 50% of you said, yes, I've cared for a patient. 50% said no. And then the question about, did you experience personal moral conflict when caring for this population is yes, no, and I'm not sure. And this is a really difficult one, because when you're caring for a pregnant patient, many people perceive it as two patients. So you have the pregnant mother, and then you also have the fetus. And so in those situations where there's an action that is taken by the pregnant patient, it then affects the fetus. And if that action is harmful, such as substance use disorder, there is an effect on the fetus. And many of you who cared for patients know that that is neonatal withdrawal, where the patient actually has this, the fetus actually has the symptoms of withdrawal similar to the mother. So because of this, it's really important as nurses, as nurse leaders, to be able to approach these patients in the most appropriate way. We know that legislatively and through policy, a lot of the strategies to address this issue is criminalization. So states want and have laws, they want to put pregnant women in jail and not really address the health issues around substance use disorder or around protecting the fetus and also benefiting the mother. So we have a position statement. ANA has a position statement about the non-punitive treatment for pregnant and breastfeeding women with substance use disorder. And the goal of this position A is to just take a hard stance and say, you know, as an organization, we believe that substance use disorder is a disease. A lot of people treat it as a moral failing. That is not the position of ANA, and is not the position that we guide nurses to take, right? So when nurses are caring for pregnant women, we care for them with respect. We care for them with compassion and understanding. And so women who are pregnant who present with substance use disorder are treated as such. So in this position statement, and we encourage you, we'll give you our contact information at the end, but we encourage you to really sift through all of these position statements that we're talking about to really get a deep dive into understanding that there are different perspectives, right? So that again, some states are coming to this saying we should put these women in jail, it'll protect them, they won't have access to substances, when we know that's not true. We know that people can still get access to substance use disorders and still have them while they're incarcerated. So they're again not treating the disease. And then we also know that because of that, pregnant women will not seek services. They won't trust the system, they won't trust their provider, and so they will not get any prenatal care whatsoever. And again, that's detrimental to the mother and the child. So we'll go to our next poll question.
So our next poll question has to do with pain and suffering. So have you ever grappled with caring for a patient who is requesting a prescription or the administration of pain medication, but you are unsure if it is clinically appropriate? And then there will be a follow-up question to this which hopefully we can have some people come off mute and share. But we're still within the poll. Have you ever grappled with caring for a patient who is requesting a prescription or the administration of a pain medication, but you are unsure if it is clinically appropriate? Okay. So this one we have, it's not 50-50, but more people are saying yes. And then about 40% of people are saying no. So I'll go ahead and end the poll here. And then the follow-up question to this, we'll have some time to kind of discuss, but what are some of your concerns in this situation? And if you would like to answer, please use the raise your hand emoji and feel free to share. Rashida?
Hi. I think in this situation, the hard part is like advocating for the patient in terms of usually in terms of pain management. I've seen it a lot with mostly sickle cell, but then also making sure that the patient is safe. And I have seen patients get, patients where people of color get less. But then like also making sure that the doses are safe and like while you're advocating for them as well.
Right. Yeah, absolutely. The position statement that I'll show you in just a moment talks a lot about that, Rashida, and that's that tension between a nurse's duty to manage pain and the duty to avoid harm. So that's a very real conflict that nurses encounter in this situation. Does anyone else want to share what are some of your concerns in this particular situation? So one of the things that I kind of flipped this question a little bit, right? So it's one thing to grapple with if it's clinically appropriate to prescribe the medication, right? But we also can grapple with what Rashida alluded to, and that is, what are the biases or the things that potentially our colleagues can insert into situations, or the things that we may view that are affecting the treatment of a patient, even if we are an outsider or a bystander in the situation and we kind of have a handle on what's going on. How do we grapple with that part as nurses? And so if you can advance for me, Liz, to the next slide. This is our position statement regarding the ethical responsibility to manage pain and the suffering it causes. So in this position statement, we talk about the many factors that make it difficult and sometimes impossible to help patients who are experiencing pain. And among these are things like moral disengagement or knowledge deficits or biases, environments that are not conducive to optimal practice, and even economic limitations. So how does moral disengagement show up? One way that it can show up is blaming and dehumanizing patients for health problems like substance use disorder or opioid addiction. How does knowledge deficit show up? It can show up in the lack of knowledge and understanding of best practices for assessing and optimally managing pain. We talked about how some of the biases can show up. So we can insert our own experiences with pain. We can insert our own personalities. We may have had situations where we accompanied a family or friend throughout, a journey of pain. And so we are bringing a lot of those things to the table when we're caring for patients. It's important for us to check those things and be mindful of those things. And so all of these factors are constraints on nurses meeting their moral obligation to relieve pain and the suffering that it causes. So this again is another really, really great position statement.
Thank you,
I
Kara.
think-
And go ahead. I'll just add to that really
Mhm.
quickly. As we're thinking about what is your role as nurse leaders, as nurse researchers, as nurse educators, nurse researchers, we need you to do research, right? So we need you to do the research, especially on patients and people of color, to really understand what the connection is between pain and understanding, because we say the pain is what the patient says it is, but really understanding what that pain is for people of color, and whether or not the medications and the treatments that we're using are effective or are beneficial, because we know that there can certainly be differences there. But it's also the advocacy piece. And, Rashida, you mentioned this. We know that oftentimes people of color are not heard, right? So it's always like, oh, that person is always complaining about their pain, or they're pain seeking. Or I always hear, oh, he doesn't look like he's in pain, right? If he's comfortable or if he's stoic, etc. So really making sure that we advocate for people of color, or those who are, don't have a voice, who are often marginalized in this discussion around pain. And I also just want to acknowledge the comments in the chat. And Teresa, thank you. She says, I've dealt with this more often with benzodiazepines than pain medications, especially for transfer patients. And that's a great point. Again, it's making sure we're listening to our patients and making sure we're advocating for our patients' needs. And then also too, Vicki asked the question, how does this relate or apply to patients or clients who seek medical marijuana cards for pain or anxiety? And it's interesting, we're actually going to talk about marijuana. Hopefully we'll be able to get to it at the end, but this is so true. It's like, how do we make sure that we're managing pain in the most appropriate way for that patient, and however they need to seek or treat their pain is really critical, that we're listening to them and adjusting where we need to, instead of doing the traditional, oh, you're going to get this, oh, you're going to get this. Understanding everybody's pain journey is very, very different. All right, our next one kind of dovetails a little bit into the discussion about health disparities and the racism and bias that exists. So our question for you, do you think nurses have a responsibility? I know this is going to be 100%. Do nurses have a responsibility to understand and address the impact of structural racism? We've got absolutely 100% here. I'll share the results. And so I'll throw it out to you, because this is a deep, complex question, but how do we do this? How do we make sure that we are understanding and addressing the impact of structural racism in our profession? Uriah.
Yeah, I think one, we need to exemplify what it is to care for patients who are disenfranchised. And we're also to be brave enough to call it out whenever we see it. Sometimes we engage in conversations that have those biases, and instead of calling them out or acknowledging that, hey, this is a problem and it needs to be addressed, we tend to join in those conversations or remain silent. And so I think we can, by just exemplifying the ethical and moral principles to which we signed up to as nurses, and also call it out when we see it.
Absolutely, 100% agree with you. Thanks, Uriah. Melissa.
Hey everyone. Honestly, I think a lot of it starts from figuring out where you're coming from initially, because you may witness things that are okay within your own circles, but outside of them, they're totally inappropriate. So it's really setting that boundary and clarifying it and having those conversations. They're very difficult to, I would say, entertain, but it's if you know where you're coming from and you're able to express that and find the words for it and have the conversation trying to remove the emotional impact that it has on us, I find that it's more effective of a conversation. And it may also tell you, this is not the right space for me. I can't stay here. So it's really, where do you come from, and not allowing a lot of different things that you wouldn't stand for kind of change your perspective, but being able to see it and understand the conversation is important.
Thank you so much, Melissa. Very powerful. Vicky.
Yeah, I was just gonna say, I think it's helpful to address it for those of us who are researchers too, to make sure that we're including this aspect of it to whatever topic you're studying. You're researching is very important to consider the racial impact of whatever those health challenges are. Speaking about all the different disparities, so making sure that we address it in our research so that we can speak more with more evidence base about the impact of it too.
Absolutely. Data is so critical in this conversation. Thank you, Vicky. Kamisha.
Yeah, I think as it relates to what Melissa was saying, sometimes it's understanding what it means to you. So I started clinical today in a site in the DMV. There were no providers that looked like me, no advanced practice providers, no RN coordinators. And I mean, like going into a place like that, in a place as diverse as the DMV is just difficult and challenging, but also realizing that us in our studies who are studying to be DNPs and PhDs and nurse practitioners, right? Like just being present and understanding that like we are moving and changing the workforce. And that just like us as we're studying and it's difficult doing the work so that we can be there to make the change for the next generation. That is what I am reflecting on as I hold like the difficulty of like no one there and also saying like, but I am here and I'm coming forth to meet the need.
Thank you so much, Kamisha. And I'm sorry for that experience, but I really love the positive flip that's amazing. Thank you. I saw another hand. Elizabeth.
I think we need to lead the examination of existing policies within our institutions and look at that carefully, revise it to be to dismantle racism. I think we need to lead and change those policies.
Thank you so much, Elizabeth. Agreed. Giandra.
Thank you. I think we need to remember to go where nurses are, where the school, I think we need to go to the schools and be part of faculties where many of the faculty members are not very many people of color, and nursing students aren't seeing representation of people of color among the faculty. So I think that is a good place to begin as well.
Thank you so much. Any other comments? I don't see any other hands.
And if I could, Liz, because when everybody was speaking, I was referencing our position statement, which is the nurse's role and responsibility in unveiling and dismantling racism in nursing. And so much of what everyone said is reflected in this position statement in regards to the practical guidance and answering that question of how we do this. Just a few things, and I can't remember who said what, so I would have liked to call out your name for your comment to then say to you, based off of what you said, let me share this with you. As it's related to research, one of the recommendations in our position statement that we offer is to identify and advocate for the dismantling of racist context, underlying evidence-based research results. For nurse educators, someone made a comment about showing up in the academic space. It's important to identify, to understand the essential roles in student professional formation and the development of moral character required for the practice of advocacy and the provision of equitable, respectful care. It's so important for us to move beyond the focus on patient behavior. So in practice, right, to move beyond patient behaviors and compliance with prescribed interventions, as we were discussing just moments ago with pain, and actively engage with and attend to the socially constructed disparities and inequalities, both experienced and propagated by our own profession. So everyone has mentioned something that is touched on that can translate to all practice settings, all nurses, to nurse leaders, to nurses in academia, to nurse researchers. So I was just so grateful to hear the responses that you all shared.
Absolutely. I was going to say, you must have read our position statement, even though it just came out. You must have read it. And I think the first individual, I think it was Uriah, said, you know, when we see it, we got to call it out. That's so important. It often comes with a risk, right? We know that, but we have to call it out. We cannot be silent when we see racism or racist behaviors existing. And that is the way to change, right? That is the first steps to make change. So thank you all for your comments and feedback. And Elizabeth, I see your hand. Is that from before, or did you have a new comment?
It is from before, sorry.
Okay. No worries, just making sure.
Thank you.
Absolutely. All right, moving on to our next position statement. Our question for you: have you ever wrestled with how much decision-making capacity to consider when caring for a person with an intellectual or developmental disability? So how much decision-making capacity when caring for someone with IDD? It looks like maybe, I was gonna say the majority. It's on my end, you can see it moving. Or about maybe 60% said yes. Let me just make sure if there's anybody else. All right, I'm going to close it out. So about 63% said yes. You've wrestled with how much decision-making capacity. Can you talk about what some of those concerns are? And feel free to raise your hand, or Uriah, go ahead.
Yeah, I think for me, sometimes, decisions are made, especially a patient with some kind of a childhood disability, intellectual disability. They're not able to speak for themselves for the most part, depending on the severity of the condition. And, a lot of times decisions are made to treat these patients based on their behavior. And especially, I feel like, those who are, again, of a different racial, like Blacks and stuff, I think folks are more quick to start them on medications that are, antipsychotic medications and mood medications in order to deal with the behavior. And sometimes that's necessary, but I think it's important that it be weighed with the safety, and that there are discussions happening across the board whenever those decisions are made. And, but I feel like we are unfairly targeted as the minorities for medications as a first choice to deal with behaviors that are related to these type of conditions. I'm hoping I'm answering the questions appropriately as you ask, But,
you are. Thank you,
yeah.
Uriah. Thank you. Melissa.
It's funny. Honestly, a lot of the challenges that I come to are usually, because I work with veterans, it's usually connected to those with TBI. They may have been fine and they were driving and life was great. And next thing you know, they can barely put their shoes on, or whatever it is that may be going on with them that specific day. So the challenge that I find with most of them is they're able to make decisions. It's whether or not they're able to process what the decision means for them, like medication management, different types of medications. And no, I won't do lab work. I have a veteran that hasn't had labs for 3 years. So I'm just medicating them because I don't know what else to do with them. So it's one of those things where you talk with them and you spend that time with them, but as soon as the conversation's over, it changes, or their perception or recall of whatever you discuss changes. So it is challenging. And I think it's more of making sure that they understand whatever's going on and being able to implement that in the moment, and having them and being able to assess it once you do it. So that's kind of where I come from with it.
And that's a great point as you're talking about capacity, because capacity in the moment, yes, you have capacity to make this decision, but does someone really understand the consequences of the decision and what all is involved? And I think that's what I'm hearing you're saying is that's the challenge with the population that you serve.
Yes.
Thank you, Melissa. Teresa.
I currently work with a indigenous population in northern Nevada, and have dealt with been presented with a couple of issues recently, wherein the family or a member of the family wants to become a guardian for a patient, basically just to become the payee, to have this. And it sometimes it strips away the patient's autonomy, and well, not sometimes, it definitely strips away the autonomy, and then there's this conflict, and so at times there's a request from tribal court for the nurse practitioner to do an assessment as to whether it is necessary for the patient to have a guardian or have a payee, and so this is when it's really important to make sure that you're looking at the facts, but also understanding the family dynamic and what is driving some of these decisions and what are the intentions behind all of this.
Thank you so much, Teresa. And again, you guys have really touched on the heart of many of the components that are in our position statement. So we have a position statement that's really talking about how do you ethically care for people who have an IDD. And it's really a challenging situation because you have this balance between trying to give autonomy to that patient and to that individual. But if they may not have full decision-making power, you've got to lean on others. You've got to lean on the caregiver or their family or whoever's designated as a guardian. But what are the intentions of the guardian? And sometimes that can really get tricky. And one of the things we talk about is this caregiver impact, and the impact that someone who is caring for someone with IDD, especially if it's been for a lifetime, right? So if it's been for years and years, they may have a very different perspective of what is necessary for their child or for their parent or whoever the individual, whatever that relationship is, than the care team. So there's the conflict. And Teresa, I think you spoke to this earlier. That is exactly the challenge of ethically, what do you do as a nurse practitioner, and how do you try to protect that unit, right? Protect your patient and give your patient as much autonomy as possible, but also making sure that that individual is not harmed. And again, it's very difficult, it's very tricky. And one of the things that we advocate for in this position statement A is to make sure that we are protecting our patients, but making sure we're giving them the most autonomy possible. And there's so many complex life components to think about. So we talk about reproductive care, right? So when someone who has an intellectual and developmental disability, we cannot assume that they don't have the right to reproduce, right? That is an unfair assumption, but we have to make sure that we have those conversations and make sure that if it is done, it's done in a safe way. But then we're also talking about, end of life, like when someone reaches the end of life, what does that look like for them and when does that occur? And again, a lot of the times in healthcare, it's the assumption of we dehumanize this population because they may not be able to literally speak for themselves. And so they get dehumanized. And, we think about COVID-19, there's a lot of data already out now that some of these patients and these individuals were, as we're thinking about rationing care, they were lower on the tier, right? So they did not get the services that other people got, and they really experienced tremendous health disparities, as they do. COVID just exacerbated health disparities for so many populations, but this was certainly a population that is often referred to as the hidden population. And the other thing, and we talked about this a little bit before, but I think it's a notable piece throughout all of the position statements that we've covered. And this is how we talk about populations, how we talk about whether it's disadvantaged or disenfranchised populations, how they are referenced in our materials, in our teaching materials. for nurses and for nursing, whether or not they're even mentioned, and if they are, how they're referenced. And so as nurse leaders and advocates, especially in academia, we've got to connect with our publishers. If we are the editors of the textbook or the journals, we have to make sure that we're using language in terms that are inclusive. And if we see something, call it out, contact our publishers, contact our editors to make sure that language is changed, because it then just continues on. As nurses continue to learn in these textbooks, that cycle of, the incorrect terms or incorrect non-inclusive information just continues. Anything additional, Kara, you would add before we move on?
Just even to that last point about even how we choose what information and the literature that we gather to come up with these position statements, and being intentional about the representation, and how we decide who we are referencing in these position statements. So I think that was just an additional point to what you just stated.
Thank you, Kara. And the next question I will ask is just a question. It doesn't necessarily have to be about individuals with intellectual developmental disabilities, but have you ever thought about or worried about placing restraints, or if you are in a position to order restraints on patients in this population when they may be physically combative, or there's a risk of harm to you or to others on your team? So any concerns, you can type in the chat box, any concerns, or you feel free to say anything about restraining patients in this population or not, but when they're physically combative and there's this risk to yourself or your team. Melissa.
So I've actually had this experience a few times before working at the state hospital, and I found that it doesn't matter how long you place someone that's developmentally disabled, whatever is going on, and restraints, they never really get it. They don't understand it. It doesn't make sense to them. So I've kind of moved to a position where we may have to do what we call a physical hold, and a lot of facilities don't really acknowledge this as a true restraint, even though it is, where you may have 3 or 4 people holding that person still until they calm, trying to do like a calming method, like a bear hug. And we found that it works. It's just very difficult to do. It's not taught in de-escalation classes. It's not really something that you learn how to do as a professional moving through the mental health field. You kind of learn it from having little kids with temper tantrums. So I'm sorry, I looked at somebody put Dr. Atwell put a message. It's really just depending on what's going on, what happens with that patient, if they need to receive medication, because maybe they've been acting out all day. So it may be we have to medicate this person. And unfortunately, this is where we are. But I found mechanical restraints they're not that effective for them over time.
Thank you, Melissa. Tina.
Yeah, and I agree with Melissa too, because working in a state psychiatric facility, it got to the point where being the charge nurse, I would just say, no, don't tie no one down. And I've come to see that just leading them into probably the seclusion room that is padded and just have them calm down while they're in there has always been more effective, to the point that the entire hospital stopped mechanical restraint, because at the end of the day, sometimes the patients get hurt while on restraint, and that doesn't work for anyone. So mechanical restraints, no. A lot of times just give them, like, kind of telling a child, have a timeout. We'll put them in the seclusion room, padded, and just give them whatever they want in there. And when the tantrum is over, they calm on their own.
Thank you so much, Tina. And you both made such great points. And there's a chat box or chat message as well that says, restraints can lead to death, and we certainly know that. And so it's great to hear that you guys have sought alternative methods. And I hear you, and I'm like, oh my gosh, this is an area for research. So you're like, oh yeah, there's no policy around this. There's the gap, right? So there's the gap that you can fill through research and policy actions physicians to make sure that, if you can really demonstrate through evidence that this is a more appropriate way to restrain people, do that research and share that with others as well. But I just wanted to highlight, it's really difficult with restraints and knowing how to make sure that your staff is safe or that you are safe, especially if someone is being combative, but making sure that your patient is safe at the same time and really understanding what is that risk, right? So as a provider, as a nurse, what is the risk to ourselves that we could possibly be endangered in order to make sure that our patients are safe? And that's what this position really outlines. And again, it speaks to exactly what you just said, is finding alternative methods to make sure that patients are safe and calming patients and addressing what might be the trigger that is making them, demonstrating that combative behavior, whatever it is, trying to address that rather than just saying, put them in restraints, understanding, and we know this all too well, that sometimes we don't have the staff, right? So we may not have the staff that's able to, do that 3-person bear hug or be able to be with someone on a one-on-one, or, you just may not have the resources to address that person individually. But that's not the answer, right? So just because you don't have enough staff doesn't mean that you restrain people, but really finding some innovation and doing our research to make sure we can find alternate ways to make sure that people are safe. So thank you guys so much for discussing our position statements. We want to just go ahead and highlight just one more piece of advocacy and leave you with a couple of to-dos as we talk about advocacy in this effort. So as nurse leaders, it's important that, as you're thinking about advocacy, that your patient-focused practice changes or process improvements, that's what you're really trying to do, is improve process. So now that you are stepping into this nurse leader role, or you've been in this nurse leader role, how can we make nursing better? Things such as workplace safety policies, staffing, safe patient handling, and mobility, really identifying, again, what are the gaps in practice and the gaps in processes that can be improved. And then representing the issues of our patients, our patients, our consumers, our profession, ourselves, making sure that we have all of these things in the forefront of our mind, and then championing the courage and ethical action to actually do it. All of this takes time, change takes time. And I always say, but if we don't do it, who's going to do it? And so really understanding this is our calling, this is our ethical obligation as a profession.
And then in an effort to strengthen our profession and to contribute to a more healthy society, we need to ask ourselves, what can we do and how can we do it? So these are some things that we wanted to offer that I'm sure most, if not all of you are doing one or all of these things. So I apologize if my kids are coming in from basketball. So we can influence elected officials and other key decision makers by building relationships. Obviously, we can get out and vote. We can serve on a committee, a council, or a board, and we can run for an elected or appointed position. These are how we really, these things are how we really make an effect and change policy and influence policy, and making sure that nurses are at, as Liz talked about earlier, pulling up that chair to create their seat at the table.
So I just wanted to give you some examples of nursing advocacy and boards that you can think about being a part of or really directly affecting their profession. So, sometimes I talk about this to undergraduate nurses and I'm like, somebody writes that NCLEX, that test that you're taking, somebody wrote that, right? And it's nurses and understanding the impact that, we can be a part of the NCLEX committee. We can be on the writing committee, the review committee, we can be on the statisticians committee. Like, we can really be a part of this process. I hear so many complaints about the NCLEX, and it's like voting. It's like, okay, well, how can I make a change? Another body is the American Association of Colleges of Nursing, and this is AACN. They help set the standards and credentials for nursing education. So they kind of outline what should be, they write the essentials, what should be a nursing curriculum. Again, they have a volunteer body, a volunteer board, where nurses really come together and help write these essentials and help identify and shape our profession. And then something that might be local to you is through your local nurses association. So Maryland, there's the Maryland Nurses Association. There's also the DC Nurses Association as well, and other specialty bodies. So if you're in psychiatry, American Psychiatric Nurses Association, AACN is critical care. And then of course, NLN, again, another credentialing body that sets the standard for many schools of nursing about what schools of nursing should do, how many courses, how many credits. They really help do that credentialing piece. And if you are looking for a board to participate in, there is a group called Nurses on Boards Coalition. So again, it's Nurses on Boards Coalition, and it's kind of like, I'm probably going to date myself, but like Match.com. I don't even know if Match exists now, but all, Bumble and all those great sites, they match you. So you put in your application and then you say what your interests are, and they will match you with a board and put you together if that's something that you're interested in, and you can participate on a board. But again, it's just really so critical that we lean into our leadership and we lean into our advocacy, because if not us, then who?
So we just wanted to really take the time to thank all of you for joining us. This is our contact information here. I know there was one unanswered question, I think, from Vicki about the medical marijuana, and we'll share that position statement with you. Vicki, I'll put it in the chat. But you can always reach out to us, either one of us. Our email addresses are here. We always want to plug the fact that we are coming up on the revision of our code of ethics. So the document that we discussed in the beginning of the presentation, that we go over, we do a 10-year revision process every 10 years. And so that's coming up in 2025. And so we're gearing up for that. And so if there are any issues or things that you think of, or things that you feel like should be included in the code of ethics based on your expertise, based on your experience and the work that you do, please feel free to reach out to us. So we'd like to thank you again so much. And if you have any questions, I think we have like 4 minutes, because I know you have to do your surveys, but we welcome any questions at this time. Vicki, I just put in the chat our position statement on therapeutic use of marijuana and related cannabinoids.
Thank you.
You're welcome.
Any questions about anything, about the Center for Ethics, about advocacy? All right. Hearing none, I will turn it back over to you, Janet. Thank you, everyone.
Thank you.
And thank you, Dr. Liz Stokes and Kara, for that very, very enlightening presentation. I'm sure everyone gleaned some nuggets from that. Also, at this time, we'd like for you to take the time we have left to complete our survey. It is in the chat, so please, before you log off, make sure you complete that survey. The survey helps us improve our programs to better serve you. And so again, I cannot thank Liz and Kara enough for helping us kick off our webinar offerings this year. Thank you so much. We really, really appreciate you.